Welcome. Let's talk about when it's appropriate to repeat a spirometry or a pulmonary function test. In general, the answer is you don't have to. As long as the patient's clinical status is stable, they don't have any new respiratory-related symptoms. The other time I don't want to repeat a spirometry is when a patient is admitted to the hospital for a respiratory-related complaint or even pneumonia. At that point, because it's not going to be reflective of their true baseline. I do tend to repeat a spirometry when they do have respiratory worsening or complaints as an outpatient, not when they come into the office initially. If they have a known diagnosis of COPD, I go ahead and treat the exacerbation. I may choose to get a repeat spirometry during a follow-up visit or prior to the follow-up visit to assess to see whether there's any significant change. Now, a lot of the times patients' respiratory status don't really, especially with COPD, they may not return to baseline until about 8 to 12 weeks at least after the exacerbation. So I'd caution on that as well. The other time I would want to repeat a spirometry is if I don't have a recent pulmonary function test or spirometry, at least in the last 12 months, and the patient is going for a surgery or there's a pre-op evaluation. The other time that I do get a repeat spirometry is when I'm dealing with patients with interstitial lung disease, especially pulmonary fibrosis, idiopathic pulmonary fibrosis, sarcoidosis. The initial evaluation, I'll get a full pulmonary function test, and then I may get one 3 months after that, and then another 3 months after that to assess for stability or change, because any new patient, you need to figure out whether the trajectory of the ILD is in a downward fashion or whether they have a stepwise decline, or they are generally one of those that maintain their respiratory status for prolonged periods of time. So you want to put them in, you decide which box to put them in and assess for possible transplant list allocation. So in those patients, I will get a spirometry or pulmonary function test every 3 months, at least for the first 6 months, and then follow up with a 6-monthly and then yearly after that. And those are the only times. So just to recap, in general, I don't repeat a spirometry unless I have to, unless I'm suspecting that the worsening symptoms are related to the pulmonary complaints, or trying to differentiate whether I can't tell the difference between this is a cardiac decompensation or a respiratory decompensation. So at that point I may get it, but again I do not get it when the patient's actively decompensated or having an exacerbation, because it doesn't give me any information that I need. I can hear a wheeze. At that point I can't tell whether the wheeze is respiratory or whether it's cardiac in origin. Or if I hear a wheeze, I'm going to expect there's going to be some obstruction, and it doesn't tell me what the true baseline is of the patient, just because someone's at that point truly going through an exacerbation. I don't see that's reflective of what the patient's actual respiratory status truly is. All right, thank you.